Hello, we are group 25. Today we are here to talk about tamoxifen for our assignment 2, MedChem assignment. Tamoxifen is a generic name and the brand name of it is Soltamox. It is belong to class SERMs, S-E-R-M-S. It stands for Selective Estrogen Receptor Modulators. One of the SERMs approved by the FDA medication is for breast cancer is tamoxifen. The tamoxifen has been used for more than 30 years to treat hormone-related receptor-positive breast cancer. Research has shown that women who receive at least 5 years of adjuvant therapy with tamoxifen after having surgery for early stage estrogen receptor-positive breast cancer have reduced risk of breast cancer reoccurrence, including a new breast cancer in the other breast and death at 15 years.
Hi, I'm Ricardo Suarez, and to continue on, we're going to talk about the mechanism and resistance. Okay, continue on. As mentioned before, we have tamoxifen, right? It's a selective estrogen receptor modulator. Okay. And it is a non-steroidal synthetic and has antagonist and agonist activity on estrogen receptors on selected tissue, on certain selected tissues. Continuing on, it is also a competitive inhibitor of estradiol binding to the estrogen receptor, which what it does is it causes a conformational change on the receptor in the cytoplasm and inhibits dimerization, meaning that you have the cofactors won't bind to the receptor due to tamoxifen binding to that site causes a conformational change. Now those cofactors will not bind there, which would not allow cell proliferation. Okay. Now continue on. We have more of a defined picture. This is going to be your cell, okay? And here you're going to have, the cell will have, through the entrance into the cytosol, you have the estrogen coming in through. So just imagine this is the estrogen right here. Okay, that will come through. Normally that will bind to the estrogen receptor. This little box here as a U. Once it binds to the receptor, you'll have the cofactors that bind to the receptor, causes that to go into the nucleus, and then we'll have activate the cell proliferation. Okay, but tamoxifen on the other hand, what it does is it binds to the receptor once it gets inside the cell, and causes a conformational change to the receptor, estrogen receptor. Once it causes a conformational change, those cofactors cannot bind to that receptor. Now, that inhibits the proliferation. So, on the other hand, though, some estrogen receptors are tissue specific. So, for an example, on a urethra or uterine, you'll have the estrogen that will bind to the estrogen receptor, and what it does is instead of stopping proliferation and that other type of receptor, what will actually cause proliferation, it'll do the opposite. So it's really some of these receptors are specific for the tissues, so you have to be careful of what you're targeting. Okay. Now when it comes time to resistance, so when you look at resistance, what can a cell do, a cancer cell do for resistance? Well, the first thing we want to do is, what can it do? Well, what it can do is, it can polymerize the enzyme that converts the coenzyme of, the enzyme in the liver that's targeted for tamoxifen. What it does is it polarizes it. It's a 2D6, which won't allow tamoxifen to target get inside the cell. Also, another way is there's also little receptors on the cell on the other side where it's called the RAS, 2AF, and MAPK pathway. Okay, these are other receptors on the cells. Okay, and some of these receptors, you have estrogen growth factor receptor, for example. You have the human epidermal growth factor, and you have the insulin-like growth receptor. All these are receptors, and what it can do is, even though, let's say you stop it here with tamoxifen, what it can do is, it can talk between the cofactors and this receptors here, between a crosstalk, and it can actually spark up the RAS-RAF MAPK pathway to initiate, to start up, to activate proliferation. And that's pretty much the simple way that these cells can become resistant to tamoxifen.
Okay, we're doing assignment number 2 on tamoxifen. I'm going to go over the pharmacokinetic portion of it. So when tamoxifen enters the body, it is metabolized primarily by cytochrome P450 enzymes. Tamoxifen undergoes 2 major pathways at that point, either 4-hydroxylation or N-demethylation to create the active metabolite endoxifen, as well as a handful of other metabolites. The majority of remainder metabolites are produced through CYP3A4, CYP3A5, and CYP2D6. The secondary metabolite, N-desmethyl-tamoxifen, contributes to approximately about 92% of tamoxifen's metabolism. N-desmethyl-tamoxifen is actually further processed to a number of different metabolites, the most significant being the metabolite endoxifen. Endoxifen and the other metabolites created by N-desmethyl-tamoxifen has shown more significant anti-estrogenic effects in breast cancer cells than tamoxifen itself. This shows the importance of CYP450 enzyme system in the metabolism of tamoxifen. The researchers actually believe that the success of tamoxifen is most likely due to the active metabolite endoxifen as opposed to the actual drug itself. In terms of general pharmacokinetic properties, tamoxifen is easily absorbed orally. Its peak concentration is about 3 to 7 hours. It has a steady state concentration after 4 to 6 weeks of oral use, and at higher doses, it can lead to retina degeneration, and the half-life is about 14 days after being excreted in the stool.
Talk about the side effects of tamoxifen. The most common side effect is hot flashes, and it is believed that the hot flashes are caused by an anti-estrogenic effect on the CNS caused by the drug, which causes regulatory dysfunction in the body. Co-administration of CYP2D6 inhibitors, such as SSRIs, can reduce the hot flashes. However, strong CYP2D6 inhibitors, such as paroxetine and ampreloxetine, can adversely affect the efficacy of tamoxifen. Another side effect that's common is thromboembolisms to patients. It's an increased rate of the embolisms whenever it's added to chemotherapy. The rate is greatly increased in older women. However, the increased risk goes away once the patient stops taking the drug. Also, tamoxifen is also associated with an increased risk to endometrial cancer and uterine sarcoma. That's a black box warning of the drug. The risk of cancer increases. The risk of cancer increases only in women age 50 or older, but the risk of cancer continues while the patient is taking the drug and decreases after the patient stops treatment.
Cimetidine, quinidine, and diphenhydramine can cause decreased plasma concentrations of the active metabolites of tamoxifen. St. John's wort can cause a reduced effectiveness of that medication. Mitomycin can cause an increased risk of hemolytic uremic syndrome. Letrozole will have a reduced serum concentration when also taken with tamoxifen. And clobazam, don't know how to say that properly, increased tamoxifen plasma concentrations, and the use of clopidogrel with tamoxifen can result in increased risk of tamoxifen toxicity, which includes nausea, vomiting, dizziness, hyperreflexia, QT prolongation, and increase in liver function tests.